Cyst is a cavity surrounded by epithelium and has lumen-containing fluid. There are two types of cysts. One, true cysts, which is pathological cavity lined with epithelium. Two, pseudocysts, which is pathological cavity not surrounded with epithelium. True cysts may be odontogenic or non-odontogenic. Odontogenic cysts arise from epithelium involved in tooth development. Non-odontogenic arise from epithelium involved in development of facial tissues. Source of odontogenic cysts may be remnants of dental lamina, or remnants of enamel organ, or epithelial root sheath of hair twig. Odontogenic cysts may be inflammatory due to inflammation such as radicular cyst and peridental cyst. Arise from rests of molluscs. Or may be developmental of unknown cause, such as dentigerous and eruption cysts, which arise from reduced enamel epithelium, and odontogenic keratocyst. Calcifying xerodontogenic cyst, lateral periodontal cyst, botryoid odontogenic cyst, gingival cyst of adult, gingival cyst of newborn. Arise from rests of serous. Radicular cyst. It is a type of inflammatory cysts. There are three types. Periapical cyst. Arise apical to root, lateral cyst. Arise lateral to root surface. Residual cyst. Arise from remaining or extracted tooth. Periapical cyst develops from pre-existing granuloma. Granuloma appears due to inflammatory process as a result of tooth infection. When the blood supply of the granuloma is inhibited, the granulation tissue at the center of the granuloma starts to degenerate, become necrotic, and liquefy into proteins. This creates an epithelial-lined cavity filled with fluid, leading to progressive increase in the osmotic pressure inside, which cause transfer of fluids from outside to inside in attempt to equalize the osmotic pressure, and slow enlargement occurs. This growth stimulates osteoclastic bone resorption to enlarge the bony cavity, and this allows expansion. Clinical features associated with non-vital tooth: painless and less infected. Large, rounded, hard, bony swelling. Crackling sound occurs later when the bone reduced to eggshell thickness. Soft fluctuant swelling, bluish in color beneath mucosa when overlying is resorbed. Treatment: small-sized needs enucleation, while large-sized needs marsupialization. Peridental cyst. Cyst arise due to inflammation of partially erupted tooth. Third mandibular molar usually affected. Related to vital tooth and shows pericoronitis. Treated by enucleation. Developmental cysts includes lateral periodontal cyst. It is a developmental cyst, occurs lateral to the root of a vital tooth. Clinical features: it occurs in the mandibular, premolar, and canine region. It is asymptomatic unless being infected. The adjacent teeth are vital. Radiographic features: round or teardrop-shaped radiolucency with radiopaque margin along lateral surface of vital tooth root. Most cysts less than 1 cm. Treatment: enucleation. Variations: botryoid odontogenic cyst. Variant of lateral periodontal cyst with high tendency of recurrence. Has polycystic appearance. They show grape-like cluster of small cysts. X-ray shows multilocular radiolucency with radiopaque margin. Gingival cyst of adult. It is soft tissue counterpart of lateral periodontal cyst. Occurs in premolar and canine area. Painless soft tissue swelling of the gingiva less than 1 cm. Odontogenic cyst. Developmental odontogenic cyst arise from reduced enamel epithelium surrounds the crown of an impacted tooth and attached to the tooth crown at semintonemal junction. Clinical features. Usually occurs in third molars and maxillary canines, which are the most commonly impacted teeth. Usually occurs during the second and third decade. Small cysts are completely asymptomatic. Large cysts may associated with bone expansion. May become infected. Radiographic features. Unilocular radiolucency with radiopaque margin surrounds the crown of the impacted tooth. Cyst to crown variations. Central, cyst grows around crown only. Lateral, cyst grows lateral to the tooth with partial coverage of crown and root surface. Circumferential, cyst grows around both crown and part of roots. Treatment, enucleation and removal of impacted tooth. Marsupialization in large cysts to allow shrinkage. Complications. The lining of the cyst may undergo neoplastic transformation into odontogenic tumors. Ameloblastoma tumor. Adenomatoid tumor. Squamous cell carcinoma. Interosseous mucoepidermoid carcinoma. Jaw fractures. Variations. Eruption cyst. Soft tissue counterpart of dentigerous cyst develops around the crown of erupting tooth. Clinical features. Appears as soft, often translucent swelling in gingiva overlying the erupting deciduous or permanent tooth. Most commonly associated with first permanent molars and maxillary incisors. With trauma, blood may appear within cystic fluid which result in bluish color referred to as eruption hematoma. Treatment. No treatment is needed, it ruptures spontaneously. Keratin-containing cysts. Odontogenic keratocyst, primordial cyst. It is a developmental cyst that has distinctive form as it is filled with keratin. May have aggressive clinical behavior and high recurrence rate. Many researchers consider it as benign cystic neoplasm instead of cyst arise from rests of dental lamina or enamel organ. Pathogenesis. This cyst shows mural growth mechanism in contrast to other types of cysts which depends on osmotic pressure mechanism. Clinical features. Mandible involved more. Usually occurs in second and third decades. Small keratocysts usually asymptomatic. Large keratocysts cause painless swelling unless infected. Tends to grow in anteroposterior direction in medullary cavity of the bone. Cyst lumen contents. 1 keratin, yellowish white or dirty white material without offensive odor. 2 plasma proteins, estimated by electrophoresis of cyst fluid. Radiographic features. Showed as unilocular well-defined radiolucency, resemble residual cyst. Multilocular radiolucency, resemble simple ameloblastoma. May be associated with an unerupted tooth, resemble dentigerous cyst. Types of keratin inside the cyst. 1. Parakeratin. Show persistent nuclei of cells. Represents 85 to 95% of KOC. More aggressive. High recurrence rate. Corrugated surface. 2. Orthokeratin. No viable nuclei of the cells. Less common. Less aggressive. Low recurrence rate. Smooth surface. Causes of recurrence. Thin friable cyst wall. Budding of cyst into medullary spaces. Budding of epithelium into connective tissue. Presence of daughter cells. Treatment. Best treated with surgical excision and osseous curettage or ostectomy as it has high recurrence rate. Variations: keratinizing and calcifying odontogenic cyst, Gorlin cyst. Developmental odontogenic cyst, cystic variant, and a solid variant which is aggressive and regarded as neoplasm. Source is rests of dental epithelium. Clinical features. Affects maxilla more. Age, before 40 years old. Involve incisor and canine area. Painless swelling unless infected. Radiographic features: well-defined unalocular radiolucency which may contain radiopacities. Sometimes small radiopaque foci be so equal and diffuse, giving a salt and pepper, ground glass or orange peel appearance. May appear as multilocular radiolucency. May associated with an unerupted tooth. Treatment. Enucleation. Eruption cysts of newborn, bone cyst. Small superficial keratin-filled cysts found on the alveolar ridge of infants. Source: rests of dental lamina within soft tissue. Clinical features: small multiple whitish papules on the mucosa of alveolar ridge of infants. Maxilla involved more than mandible. No treatment is required.